And thanks to Rishi for also including me as a part of this wonderful microbial keratitis course. It's really been put together very nicely. At the outset, I would like to acknowledge all those in our cornea care services who have also helped in the patient care of the following patients whom I'm just going to show to you. Dr. Archita, Dr. Nupur, Dr. Radhika Tandon, who are all our cornea physicians and surgeons, and Dr. Seema Sen, our ocular pathologist, for giving us excellent supportive services. So, this is the patient which I did see, and this is how the patient presented as macular leukomatous opacity, highly photophobia, severe ocular irritation, would not open up both eyes, would not allow even a decent slit lamp evaluation without the aid of anesthetic drops, and even with which it hardly lasts for just a few seconds. Any thoughts on the diagnosis? Of course, I was able to make the diagnosis only when I saw him having reached this stage, and did miss out on the diagnosis when I saw him much earlier. I don't have those earlier pictures. Was under follow-up with me for about 9 months or so before he reached this stage. And though he was very non-compliant to treatment advice and follow-up, when I first saw this young gentleman who's around 22, 23 years old, on a desk job, and which he finally had to quit because of his severe symptoms and severe irritation. And when I first saw him, he was 618 in both eyes with a myopic refractive error, was correctable in both eyes to about 6966. He presented as a case of recurrent viral keratitis, epithelial lesions, and mild anterior stromal involvements, which would heal with antiviral therapy. One episode treated outside, one episode when I did see him, he was on a healing stage, so withdrew all antivirals, put him on lubricants, and he went home happily, gaining about 612 vision in both eyes. And though at the initial presentation it was not symmetrical, and he would present with each of the eye at every episode, and infrequently wouldn't turn up once his symptoms seemed to be a little bit elevated. But when he reached this stage of a significant opacification, and he came to me after a gap of about 4 months or so, and then is what I realized my error was. He initially presented as recurrent viral erosions, which were always misdiagnosed and treated as viral keratitis. A very common error, and especially when it is not very typical in terms of its clinical presentation. And when you closely look at these pictures, you will understand what we are looking at is a corneal dystrophy, an anterior corneal dystrophy out here, with initial presentations of recurrent corneal erosions, misdiagnosed and treated as viral keratitis. And these patients have a very characteristic, this particular dystrophy has a very, very characteristic presentation, and compared to other epithelial dystrophies and anterior corneal dystrophies, you do see them as being severely photophobic, severe irritation, and severe fall and visual acuity as well. And this is when he developed, the lesions showed up, and then we could make a diagnosis, and we did take him on for a DALK procedure. I won't run the surgery because of the lack of time here, but this is what our histopathology showed and confirmed a diagnosis. He was a classical case of gelatinous droplet-like dystrophy. Bilateral presentations, asymmetric to start off with almost near clear corneas, recurrent viral erosions, probably being infected, and did come to us for treatment for the initial episodes, and subsequently his GDLD lesions showed up later on, and when we were able to clinch the diagnosis, take him on for a deep anterior lamellar keratoplasty, and our histopathology gave these characteristic appearances of GDLD. His brother subsequently came to us and is also currently under management, awaiting his turn for a DALK. And this shows a very strong familial tendency, and this is how presentation of a dystrophy could be different when you don't have it in the back of your mind for a diagnosis. Moving on to case number 2, I again wish to acknowledge my postgraduates, Shrikant and Kishan Azmira, who had helped in the care of this patient. a very interesting patient who has been with us for about a year, a little less than a year. Works in UAE as a driver. He's a graduate and kept complaining of recurrent pain, watering, redness, diminution of vision for almost 3 years. He was diagnosed to have scleritis, probable tuberculous etiology, because Manto probed positive then and nothing else was positive in his workup. And he was started on ATT and he responded fairly well and was then taken off after his course of ATT was finished, and he was apparently normal, but he did have this recurrent scleritis involving his right eye. An entire immunological workup had been done outside earlier. When he first presented to us, he was referred to the cornea department with an infranasal scleral melt for a tectonic patch, and that's the support they wanted from us, and I did do the patch. He presented with about finger counting 2 meters, and following a successful tectonic scleral patch surgery, he improved to 612. He was very happy, went home very happy, but came back very unhappy again. The graft would not take up. The area remained largely ischemic again, and we did a repatch with amniotic membrane overlay. Didn't help him much again, and we did do an immunological workup again to see what we were missing. So we looked at the flavor of the season being multi-drug resistant infections and the pythium as well. We looked at everything possible as pan-bacterial, pan-fungal, and scrapings, of course, gave us multi-drug resistant staphylococcus. Apart from which we did not get anything. We did put him on topical and IV vancomycin because of his deteriorating condition in the right eye. And he promptly developed a nephritis, and we needed an intervention in the nephrology department, and they diagnosed it as an intravenous vancomycin-induced interstitial nephropathy. So it still didn't strike us what was going wrong. He then came back to us subsequently after a visit to UAE for his job requirements, and this time he was very bad with a severe necrotizing scleritis. So these are what his presentations were, and this is how we saw him about 3 weeks ago, with severe lesions in the infratemporal sclera of the cornea, with granulomatous lesions of the surrounding conjunctiva involving about 5 to 6 millimeters all around, and with infiltrations into the cornea for almost more than 180 degrees of the limbus. He still didn't know what we were missing. We still repeated all the immunological workups for him, and what only showed positive was a slightly raised P ANCAS and C ANCAS for him. We'll again re-looking at a different place, probably whether we missed it out. So, of course, with one ANCA positive, we could just look at vaginous, but then we got both ANCAs, which is looking at it. And this is how his eye looked at. We withdrew all the other therapies for him and put him on indomethacin and baseline broad-spectrum antibiotics. And he is currently doing well, and we are contemplating starting immunosuppressive therapy for him. What we probably missed and what we are looking at when you looked at the other eye is you're looking at a scleral melt, a quiet scleral melt, which has been there. So whether we are looking at vaginous or whether we are looking at a post or an ocular presentation of Churg-Strauss, which is a local vasculitis pathology, or a rapidly progressive glomerulonephritis, RPGN, which was earlier misdiagnosed by our immunology support as vancomycin-induced nephropathy. So these are very complex conditions, very difficult cases to look at, and very difficult to maintain and treat, but probably now we are looking at either just vaginous or a crossover of a vaginous with a Churg-Strauss, and we would shortly be starting him on immunosuppressive therapy. Moving on to case number 3. I've seen about 3 or 4 cases right now, very rare till now, and very rare scenarios, very rare pediatric keratitis scenarios, and nothing much we could really do to help these children other than supportive therapy. I think all my colleagues here would agree that this was a pediatric case about a 4-year-old child, and the father brought us was referred to us from the main department, pediatrics, and here we are looking at a case of bilateral corneal opacities, and one look at this patient, one look at his nose, one look at his mutilating features of the lips. I saw another small baby which the mother refused to allow me to photograph, had got notches on the lids, lost part of the upper lids, lost parts of the nose. The child had eaten up her own lips. A very sad scenario. These are patients with congenital insensitivity of the cornea, which could largely be a scenario which is associated with either Mobius syndromes with involvement of multicranials other than just 6 and 7 nerves alone, when 5 and 8 could also be involved in these cases. You could look at congenital dysautonomias in these conditions, early day syndromes. And these are patients, when as corneal physicians, you learn to identify. And you also learn that any surgical intervention could be a disaster. And you'll have to counsel the parents in order to give them supportive therapy so that you could help in early healing of the infectious keratitis in these cases, early healing of the erosions, and also prevent the mutilating disease and its affections it can cause. With this, I think I will close and invite you all to our forthcoming Delhi Ophthalmological Society conference in April 15 to 17, DOSCON 2016, and you could log on to do your registrations. Thank you. Thank you, Rishi, for the opportunity.